Welcome, everybody, to our session. I want to make sure you guys are in the right room. We're going to be talking about striving for excellence in Dravet syndrome, but there was some confusion on the room numbers. So if you're looking for rescue seizure, that's next door. But we're hoping that you want to stay for us and hear about Dravet. Before we get started, I'd love if you guys could scan this QR code. There's also a piece of paper on your desk or your table that can scan it, and that way you'll be allowed to follow along with the slides. And also at the end, you can get credit for it. You can see the Wi-Fi password and username is listed here, so I'll let that stay for a few seconds. But again, you can scan that QR code with the flyer at your table or via the screen. And this again allows you to follow it through your personal device. And so it's really an important opportunity for you guys to do so. So please get out your personal devices and play along. All right, we're going to start by introducing our speakers. Our title today is Striving for Excellence in Dravet Syndrome, Where We Are and Where We Need to Go. So my name is Anu Patel. I am a professor of neurology and clinical pediatrics at Nationwide Children's Hospital and the Ohio State University College of Medicine in Columbus, Ohio. So I figured when there was an SEC championship game here at the same time as AES, and that the Big Ten championship game is after, I could wear this to our session today. I'm going to let our esteemed other speakers introduce themselves, starting with Shannon.
Hi, I'm Shannon Cloud. I am Patient Advocacy Director for the Dravet Syndrome Foundation, but more importantly, I am mom to a 20-year-old named Elena who has Dravet Syndrome.
Elizabeth.
I'm Elizabeth Teal, and I'm Director of Pediatric Epilepsy at the Mass General Hospital in Boston, and also run the Dravet Center there.
And Kate.
And I'm Kate Nichols. I'm a pediatric epileptologist and professor of neurology at the Mayo Clinic in Rochester, Minnesota.
And I have to be honest, I'm very excited to be a part of this panel with these friends of mine and also wonderful colleagues in the field of pediatric epilepsy. Here's our agenda for the night. We're going to start with Shannon and Elizabeth on understanding the lived experience of Dravet syndrome, followed by a discussion with Shannon and Kate on therapeutic planning in Dravet syndrome. And at the end, we'll talk about the future of being bright in Dravet, a look at the future landscapes and treatments and therapeutics with both Shannon and myself, followed by a question and answer panel. So I'm going to turn it over to Shannon and Dr. Teal.
All right, so I'm going to start off just sharing a little bit about my family's journey with Dravet syndrome. So my daughter Elena is there in the photos. She is now 20 years old. She had her first seizure at 4 months, the day of her 4-month vaccinations. And she did not get a diagnosis until she was 4.5 years old. Obviously, a lot has changed in the last 20 years, and Dravet syndrome is being diagnosed much earlier. We're seeing genetic testing done much sooner, but unfortunately, that was not the case 20 years ago. So it did take us a lot longer to get a diagnosis. I would say for most of our families starting off, the seizure control and stopping the status seizures is the biggest concern. Obviously, we try to find whatever medications we can do to help that over time. A lot of us learn that things like behavior and appetite and other comorbidities that go along with Dravet syndrome become more of a challenge even than just the seizures. And along with that, a lot of the time it's hard to figure out what is the actual result of Dravet syndrome and having the genetic mutation, and what is actually just a side effect of the medications, and what changes can we make to try to make things better for the quality of life for the patients. Our families find that it's really important not only to have a great pediatric neurologist, but also to have a whole team of providers that are working together to really help understand the patient as a whole, not just looking at seizure control, but overall quality of life. Sometimes that involves specialists or other therapists that are a part of the team in order to help the patients. And we really want doctors who take the time to understand Dravet syndrome. And we have a very well-connected community of families, and we talk to each other a lot. And so a lot of our families will go to their neurologist with ideas and say, hey, I want to try this. And so it's really important for most of us that we have a neurologist that's open to listening to that feedback and maybe, you know, willing to consider things that might not have been something that they would have thought about trying for the patient.
Okay, go back. Can I go back one, please? Hot on the head. So my task here is to kind of give an overview of Dravet syndrome with Shannon's help. And as we know, Dravet is considered one of the developmental and epileptic encephalopathies. And in children diagnosed with this disorder, the majority of them do have a associated pathogenic mutation in the SCN1A gene. As we know, kind of with developmental and epileptic encephalopathies, it's the underlying etiology, in this case an ion channelopathy, associated with mutations in the SCN1A gene, and also the epilepsy that kind of impact on the child's and adolescents and adults' cognitive and behavioral effects. And so Shannon, kind of when you started this journey, it was probably the seizures initially that were the biggest impact, especially because she did kind of take a couple years to get the diagnosis. But you probably had concerns even before getting the diagnosis about her development and other issues.
Yeah, and that's one thing that I would say has changed a lot, because for us, we were dealing with the seizures, and at that point we didn't have a diagnosis, and we didn't know that we would later start to see cognitive delays and things like that. And at the time, our neurologist said, oh, it's just febrile seizures. She might outgrow this when she's 5 or 6. And then around age 2 is when we started to actually realize, you know what, she's not progressing quite the same way that a typical child would. And from that point on is when we started to realize maybe we were dealing with more than that. But like I said, we didn't actually get a reason for those seizures and delays until she was 4.5.
You know, and I've been doing this a long time now, so I remember those days. Back when Elena was a little girl, there were no gene panels, there was no rapid testing. I was struggling with insurance companies to pay, I think, as I told you, $9,000 to get single gene testing done. So it was a different journey for, unfortunately, many people that way. So.
And parents didn't know to ask for it, right?
Right.
It wasn't well known, so parents didn't know that they should be asking for genetic testing. And I would say that's the big difference we see now as we get families joining our community, that their child may have only had 1 or 2 severe seizures. They're getting genetic testing done, they're getting this diagnosis, and then it can be devastating for them because they haven't seen any cognitive delays in their child, and you know, they have so much hope for the future, and they really don't know what to expect. And they often join our community and they want answers. They want to say, okay, is my kid truly going to have Dravet, or are they going to be the exception to the rule? And it's hard for us, it's heartbreaking for those of us with older kids, because we wish we would have had those answers to start with so that we could have avoided some of the contraindicated treatments. But then on the other hand, it would be really devastating to get that kind of a blow at such a young age.
Yeah. So as we know, and kind of as you've alluded to with Elena's journey and story, and I have to say, that's the most wicked part of this for me, is talking about Elena with you and hearing her journey. But we know it's the seizures, and it's often the seizures, and the kind of, here's my baby now having seizures. It's terrifying for any parent. But as you said with Elena, the developmental slowing, and then kind of the emergence of intellectual disabilities, then the other neurobehavioral aspects, attentional problems, autism, other behavioral problems, and then as we're trying to learn more about the motor gait problems that come as children age. And luckily a lot of research is being done on that now to better understand that and characterize that. And then sleep disturbance. I think, you know, all of us, every meeting I've been to at this conference, it's like sleep is a big issue for anyone with epilepsy, but clearly for kids with Dravet. And then also another terrifying thing about this disorder is the definite increased risk to SUDEP. So it would be almost overwhelming to kind of learn all this with your 4-month-old child. So first, the epilepsy, kind of as you said with Elena, with her first seizure at 4 months. We know in Dravet, this initial seizure is between 1 and 20 months, but I think you're right. I think it's often around that 4 months, as you said, Elena, after her vaccinations. Very common. And typically, kind of around 5 to 6 months is what overall, but a lot of the kids I take care of had onset at 4. And often triggered by a fever or vaccination. And as we know, like Elena, the initial seizure is usually tonic-clonic or hemiclonic. And we also know with this, and I'm sure with Elena, the other seizure types develop over time. Typically the first, the atypical absence and myoclonic. And did Elena have emergence of those other seizure types?
she's kind of not typical in that way. She has not had that many other seizure types. She's had, she went through a phase where she had a lot of myoclonic, like eye flutters frequently and things. She's had some like focal seizures, but not probably as often as a lot of the families in our community do experience. As you said, typically it's tonic-clonic is the immediate need at first, and long status seizures that require a lot of rescue med to stop. But then for a lot of families, it does get harder over time because of the additional seizure types that develop that sometimes can be more debilitating for the child than even just a tonic-clonic that ends and then is over.
Yeah, I think of the kids I take care of, a lot of them will have oftentimes hours of atypical episodic seizure today, and myoclonic seizures that completely impacts their ability to interact, and also the triggers. One of my kids a couple of years ago, the heat, walking outside would cause the child to have a seizure. So that was very limiting for the child and the family. One of my other kids, just exercise will trigger the seizure. So even throwing a ball to him would provoke a seizure. So that's also a tough thing about this.
When she was younger, for sure. I mean, if she played outside and if it was at all a warm day at all, or any just excitement, even going to like a jumpy place or something indoors, like just any excitement, overheating, anything, it was almost a given that she would end up having a seizure. And so that's really hard for the families because you have to really protect your child. You want them to get to experience normal things as much as possible, but you also live with that fear that, you know, I might see my happy, smiling child having a great time, and you know what could end up happening.
Yeah, pretty tough. And we also know that with a lot of the DEEs, the epileptic seizures are often, usually treatment resistant. So that's where, as we'll talk about today, all of us are excited that now we do have some FDA-approved treatments and others in the pipeline, so hopefully that will change. And then also, especially when young, those episodes of status epilepticus are recurrent and frequent. One of my kids, who's now a young adult, I think around Elena's age, before we knew also that she had Dravet, and I was telling her I could not get the insurance to approve her genetic testing for years. She would have not at all infrequent episodes, 60, 90 minutes episodes of status. So fortunately that's no longer, but it was tough for that family. And then also we know that Dravet, as with a lot of the DEEs, but Dravet, clearly it's much more than the seizures. And I think that that's something I try to think about with every patient I take care of with epilepsy. You treat the child, not just the seizures, or the person, not just the seizures. But we know development is an issue. Normal at the time of seizure onset, which I think is also tough to have this very healthy infant, making milestones, smiling, doing things, and then kind of with seizure onset, development slows, in some cases regresses. And typically we see that apparent by 2 to 3 years of age. And the frequent non-seizure symptoms for many of our kids, and there is a spectrum like with all of these disorders, but intellectual disability, attention problems, autism, sleep disturbance, and motor impairment. And so how has Elena's journey been with those aspects of Dravet?
Yeah, I mean, you hit the nail on the head with saying it's a spectrum. I mean, it's really interesting. We find in our community that our kids have so many similarities, just some of their weird, quirky behaviors and things that are so similar, but yet they are also distinct, and their journeys are all a little different. And I think, you know, looking at all these non-seizure symptoms, I would say most parents have struggled with each of these at some point, and at different parts in the journey, one of them may be more stressful than the others. Like if you're going through a phase where your child's not sleeping, that means you're not sleeping, and it can be really frustrating. And so I think for a lot of our kids as they get older, the behaviors become much more challenging than the seizures. And so it really just is a spectrum. There are kids that may not have seizures very often, but are pretty significantly impaired cognitively. And then on the flip side, there are kids that may be doing pretty well and are having seizures daily. And so it really, there's no necessary correlation between seizure control and how well they're doing overall.
And they change also. I think one of the kids I take care of who's now around 12, he's a Dave Matthews fanatic. And during COVID, when I had virtual visits, I had trouble almost talking to the family because he would be on his ukulele or his guitar, and he memorized Dave Matthews mannerisms, and he had them. But that was a phase when he was cute and fun, and now he's having some pretty significant behavioral difficulties with aggressiveness and everything. So to kind of see that change on the journey is also tough.
Right, it's harder as our kids get older because when they're small and portable, you know, if
Yeah.
they're having a seizure, you can just pick them up and move them. And, you know, if they're creating a disturbance in a public place, you can easily get them out of there. But once our kids get to the point where, you know, my daughter's the same, she's actually about a half an inch taller than me now. And so it's difficult to manage her physically at times because, you know, I'm getting older and she's getting stronger.
Yeah, yeah. So then also, as every family living with this, and all of us realize that mortality is a big issue. Status epilepticus is frequent, often recurrent, and very high rate of convulsive status. In children and patients with Dravet, 89%, and a pretty high rate of non-convulsive status too. Like I said, the hour-long episodes of atypical absence, 23%. Then the thing that's terrifying, and I'm sure keeps you up at night, and every parent of a kid with Dravet up at night, is the risk of SUDEP. Mortality is high overall in Dravet with 8.6 per 1,000 patient years, or 11%. And then SUDEP, which every parent of any person or anyone living with epilepsy is terrified of, we know it's higher in Dravet, and it's the most frequently reported cause of death. In 4.4 1,000 patient years, or 52% of mortalities in Dravet related to SUDEP. So is it okay if I ask how that has been for you?
Yeah, I mean, I think it's a frequent topic in our community. When a family gets a diagnosis, do you want your neurologist to tell you about SUDEP? Because there's a lot of families that have never heard about it, and then they join our community and they hear about it, or they learn of somebody that passed from SUDEP, and you know, I think our community's pretty split on whether they want to know. Some parents are like, oh, I really wish I had known that, and other parents don't want to live with that fear. For me personally, I can't imagine losing a child to a cause that I did not know was a possibility, and so I think for many of us, we at least would want to hear the term, you know, maybe not have a long in-depth discussion about it, but we would want to know that it's a possibility because it certainly changes, you know, maybe your nighttime setup for sleeping in terms of how you monitor your child and things. So it's a very real fear that we live with every day. My daughter does not sleep in bed with us. She sleeps in her own room. At some point in the middle of the night, she comes into our room. We do have, you know, 2 different kind of monitors on her and things. And, you know, every morning when she comes in, it's like kind of a relief, like we made it through another night. And that's obviously a hard thing for a parent to think about every day.
Yeah. No, I recently lost a 27-year-old patient I've been following for a long time. Hard. Mm-hmm. Impact of seizures then also huge for children and families with this, hospitalizations and home medical care visits, the cost of care. Again, reason I'm really happy we're having these treatments that appear more effective than our other anti-seizure therapies, et cetera. And then I think with this, with many of the DEs, particularly this disorder, you really do become a medical professional parent. More so, you're constantly monitoring your child, constantly. You're constantly training in seizure first aid, not only your family, siblings, teachers, everyone in Elena's life. Information seeking, I think that's what I've been wicked impressed by the Dravet community, and I think a lot of these now DEs, I think parents want to know. And oftentimes with Dravet, many times you might go in and meet a physician, you know way more about Dravet syndrome than your physician, pediatrician, other physicians. And then the hypervigilance, like you said, always watching for the next seizure, when she goes to sleep at night.
Right.
So that must be a tough strain for you and the rest of your family.
It is. I mean, and we kind of joke that in our community, MD stands for mommy doctor, because a lot of us do get to the point where we feel like we've studied and learned from other parents a lot of just learning what treatments have helped and what things we might want to try. And so and that's where I think every family is a little different too. Some parents get the diagnosis and they dive in immediately, and I want to connect and I want to learn. And then we have other families that kind of, they might join, you know, connect with us a little, but they're not necessarily ready to meet other parents and really learn what the future might be, because it can be hard to see. I remember the first time we went to the National Epilepsy Walk in Washington, D.C., not long after my daughter was diagnosed. And I remember seeing some girls like that were teenagers and watching their mannerisms and like, oh, is Elena going to be like that? And it can be difficult. And I think even for us, it wasn't so bad, but my parents and my husband's parents were with us. And I think for them, it was really overwhelming to see, because we had at least met a few other parents and kind of had an idea, but for them to see our, 5-year-old child and think, oh, is she going to be functioning at that level like those girls are?
Yeah, I often think if my child were given a diagnosis like this, would I disappear behind a rock, or would I seek out help? And I always try and encourage my families to seek out help, because I think having
Right.
a community is a really powerful thing. So yeah. And then kind of the impact of the non-seizure symptoms, as we've talked about, they begin shortly after seizure onset, worsen throughout childhood. This leads to increased care needs, increased impact on activities of daily living, and significant effect on the caregiver quality of life. So how has Elena's journey affected the rest of your family?
Again, this is one of these things where every family is different, right? But it really does affect the whole family, siblings especially, whether they're older siblings that are witnessing their, infant baby brother or sister having seizures and having to go to the hospital, or in my case, my daughter was my oldest, and so, her brother and sister, they've never known Elena anything other than having Dravet syndrome. And so it definitely takes its toll for a lot of families. You might not get to do the normal things that a family would do, and that can be really hard for the siblings. It can be hard for your extended family to understand that you might not be able to go to the birthday gathering because there's too many triggers for your kid. And it can really lead to a lot of isolation for our parents and families, because they don't really, they kind of live in their little bubble, and they don't really feel like they can relate to people who don't know what it's like to live with a child with epilepsy.
But I would think that's another area where being involved with the Dravet Syndrome Foundation is incredibly helpful, because there's other people who know how you feel.
It is, because at least you're not alone.
Yeah.
And we have an online support group, and a lot of parents really do find comfort in being able to vent to other parents and see their experiences and know that they're not alone. But like I said, not everybody wants that, right? Some people want to kind of hold back and not connect with other families, because it can be difficult too.
Yeah, sure. Why can I not advance these things? So the impact on caregivers, as Shannon said, I think are numerous. As Shannon said, the delay in diagnosis, taking 4 years after seizure onset to really learn why. Luckily, as you said, that's changing. Mm-hmm. And I think that it's all very exciting for all of us now with the gene testing available mm-hmm. for young children. And many times it's after that first seizure, that's being sent now. So that's fantastic. As you kind of mentioned, challenges in communication with healthcare professionals and wanting someone who will listen to you and think about more about Elena than just her seizures. Seizure management, familiarity with seizure signs and types, managing seizure first aid. It's really overwhelming because it's not just tonic-clonic seizures, semi-clonic seizures, it's all these others. Treatment and adverse events, the seizure action protocols, plans for school, for other things, and home rescue med. And again, that's not one fits all for even with every child with Dravet. I think I have many variations on a theme of different rescue meds, et cetera, and then managing the non-seizure symptoms, behavioral, sleep, motor, gait issues, et cetera. So again, impact on caregivers, ensuring appropriate IEP, and I think all of my patients with epilepsy, I think especially my Dravet patients, making sure the school understands not only seizures, but Dravet and all the other accompanying symptoms and comorbidities, and how to help her optimize how she functions in the classroom and at home. And then transition to adult care, big. Changing needs, rules, regulations, transition from pediatric to adult care. So how is your journey with that? Have you done this?
We have not completely done that. We're fortunate that our pediatric neurologist has not given us the boot yet, but we know it's a matter of time. And that's probably the biggest unmet need in our community, honestly, that we feel safe if we have a team of providers that know our child and understand Dravet syndrome, and that we've been working with for sometimes years and coming up with the best plan, and then suddenly it's, oh, I'm sorry, you're too old for our practice. And it's typically, it's not that the neurologist themselves wants to get rid of you, they feel awful, but it's that, the institution has rules and they have to follow those rules. And so we have families all the time that are like, okay, now what? I don't have a place to go. We have a Find a Doctor resource on the DSF website, and we have very few adult providers listed. And it's frustrating because a parent will go out there and look, and then they're like, but where are the adult? Why don't you have them listed? And we unfortunately have not been able to connect with a lot of adult providers, and we really want to make sure that number one, patients are being properly diagnosed. We've actually had some adult providers say like, well, I don't have any Dravet patients, and they do, they just haven't been diagnosed, probably because genetic testing wasn't around when they were younger. So that's one of our big focuses now, is to ensure that we have those adult providers that are connected with our community so that parents can continue to feel like their families are supported.
And hopefully that's also changing, because I get on the soapbox, but I think genetic testing should be standard of care in epilepsy for children and adults. So hopefully that will happen more. And then emotional, social, financial burden, decreasing social circuits for the whole family. Again, restricted activities, impact on relationships with the spouse and other children, work limitations, anxiety, depression. So it's a lot.
It's a lot. Yeah, I mean, a lot of our families have, one of the parents may have been working outside the home and they have to quit their job to become a full-time caregiver, and then that can add added financial stress. And it's a difficult place for our families to be. A lot of parents are having their own mental health struggles as a result of the stress. We say it's not PTSD, it's CTSD, because it's chronic. It continues, it doesn't go away.
And then also challenge accessing respite care to kind of give you a break, give you time with the rest of your family, et cetera. It's tough. So important discussions to have, it's not just the seizures that matter. And I think that, again, when you take care of people with epilepsy, you don't just treat seizures, you take care of the person. So I think it's important for us as healthcare providers to ask about symptoms at every visit and ensure caregivers to contact us if there are any new or worsening concerns about anything. Particularly when the kids are young, we have parents, if they do anything weird, we have parents get a videotape if they can and send it to us via YouTube. And our group looks at videotapes every day. But if we can help ease the stress on a parent wondering, is this something abnormal or normal, I think is helpful. And then also to educate the caregivers about the possible comorbidities. It's not just going to be the seizures in a kind of gingered way. You don't want the sky to fall on somebody when you say this is Dravet syndrome. But I think you need to, with realistic kind of education discussion, let people know what might happen. And also, more importantly, probably possible sources of support. So time-saving strategies for assessing symptoms, targeted questions during the patient visit. We all have increasing time crunches on the care we deliver patients. Follow-ups, I get 30 minutes, and that sometimes is a lot just to talk about the seizures. So I think coming up with a way to think about other things and the existence and impact of those possible comorbidities, including the impact on the caregiver. Epilepsy just doesn't affect the patient who has it. And then what I really like is a Dravet syndrome checklist. And maybe kind of all of us could partner with the Dravet Syndrome Foundation to come up with this, to provide to clinics, so we don't have to all think of this on ourselves, but to make it as a tool for the caregiver to complete before each visit. Now that we all have electronic health records in my patient, in my chart, it could be something to do beforehand, so we can know coming into our 30-minute visit what else is going on that you're concerned about. So call to action and discussion. So what do you think, Shannon?
Yeah, I mean, I think for a lot of us, when you're just new and starting out in this journey, you don't know what you don't know. And so if your child starts having different types of seizures, you don't know that maybe you should try a different medication, because maybe that medication would be better for that type of seizure. So, we'll have families that will post a video of a seizure in our support group and say, what is this? I've never seen this before, and, looking for answers and stuff. So I think it's really important for the parents to be able to communicate that with their provider and say, hey, this is what I'm seeing. Maybe we need to change our plan and come up with a new approach. And then, like the resources that are mentioned on the slide, DSF is an incredible resource. We have not just caregiver support, but we have financial resources such as patient assistance grants that can help a family get a seizure monitor so that maybe they can sleep a little better at night. And we do a lot of events to bring the community together. And it breaks my heart to think that there are families out there that haven't connected with us and aren't getting the benefit of those resources and the sense of community that we have. And then, not only does DSF provide the resources, but we also can suggest things for families like, hey, if you're having trouble with this, contact the social worker at the hospital and they can help you. Or if you're having issues with Medicaid, find Parent to Parents or some local organization that can help you get through that.
And then you mentioned the importance of letting parents know. And I think, meetings I've been to, Danny did and everything, when audiences are asked how many people would want to know about the risk of SUDEP, every hand goes up. So even though it's hard for us to bring up, I think it's important. So Shannon, thanks. Again, wicked awesome
Thank you.
For you to share Elena's story.
Thank you.
Yeah, thanks to Shannon and Dr. Teal for that wonderful discussion and the data that was presented. Now we're going to transition to therapeutic planning in Dravet syndrome. Shannon, we're going to start again with you, with your perspective as a caregiver.
So yeah, I think for many of us, those seizures in the first couple of years are the absolute priority. Nobody wants to see their kid having a status seizure and knowing that it's going to land you in the ER. So it's all about trying to control those seizures. As our kids get a little older, sometimes the seizure severity or frequency can get a little easier to manage. That's not the case for everyone. It was certainly the case for us that it's gotten easier. And so at that point, quality of life becomes a much bigger picture. For us personally, we know we could have Elena on more medications or higher doses of medications and probably see less seizures, but then she sleeps all day and she doesn't eat and the behavior gets worse. And so really it's about finding that balance and managing the quality of life. And I feel like we're always changing something. Not necessarily changing medications, but just sometimes just tweaking a little bit. Like, all right, we're seeing this, maybe we go up on this med a little or go down on this one, just trying to constantly find, I feel like, I've been saying this now for 20 years, but I feel like we're always like one or two small tweaks away from like finding the perfect thing that's gonna work. And I still try to keep that optimism, but it can be frustrating, trying to figure out what works best. And that's why it's so important for us to work together with the providers for that. Sometimes it can mean going back to a medication that may not have worked before. Just because at a younger age it didn't work, as our kids age, metabolism changes, a medication might work, or it might work in conjunction with the meds that they're on now, but was different than what they were on when they tried it when they were younger. Sometimes we find that our neurologists will just add more medication. Let's just throw more medication. Like, let's add this, let's try this, and not necessarily always look at like, okay, I really don't want my patient to be on 6 medications. Like, if we can truly assess that this medication is not making a difference, why do we not remove it? But on the flip side, we also see sometimes where a parent is told, we're going to try this medication and we're going to get you off this one. And that frustrates me also, because you can't just assume that adding one means you can take one away. And sometimes we find that doctors are having parents do it at the same time. And my fast rule is I will never make multiple medication changes at the same time, because then if things get better or worse, you don't know what caused it. And so I think we see kind of both sides of that. And then for many of our kids, multiple medications is pretty common. I would say a lot of our kids are probably on at least 3 or 4 medications. And for me personally, more medications but lower doses has been most helpful, because then we don't see the negative side effects. And then sometimes, there are things that would not be considered standard for Dravet, and we should not be afraid to try those things.
Thank you for sharing. When we were talking before we got going, you said that there was one big concern within the Dravet community, especially as kids get older. What was that concern?
I feel like I shared so many concerns. What was that?
Who are they going to see?
Oh, the adult provider. Yeah, okay.
Yes.
I thought, yes, the adult providers. The transition to adult care is really the biggest the biggest hurdle that most of our families are facing.
And so I'm going to ask quick, are there any adult providers in the audience today? Is that?
Yes.
Yay, good job. Because one of the issues that we frequently run into is, why aren't there adult providers? It's because adult providers come into training with the attitude of, oh, this is a pediatric disease, and so I'm not going to have to learn about it. But, these kids do become adults. And so as we are talking about creating a management plan, very few of these slides are dedicated to actual medications. Most of them are dedicated to what we as providers need to do to prepare ourselves for caring for children and families with Dravet syndrome. And what do you think about that approach?
Yeah, I mean, it's so much more than just seizures. And I think most of us, we just want to find a provider that's willing to think outside the box and consider what might be helpful. I've come into my daughter's neurologist with some pretty crazy ideas over the years. And, sometimes at first he's like, really? I don't know about that. And then over time we can have a conversation, and then, I can usually get him on board with like, well, maybe we should try this if we haven't tried something else.
And so for all the pediatric providers out there, I'm going to task you all with educating your adult colleagues because it is lack of comfort that makes them unwilling to care for children with Dravet syndrome who are now aging out of our clinics. And so, yes, the focus very much, initially seizure control, but we need to focus on maximizing quality of life and minimizing medication side effects. And so the approach that I would recommend is we need to learn about this disease, right? We need to educate ourselves. We need to be working with families because while we are supposed to be the experts on the disease, they frequently are the experts, but most importantly, they are the experts in their child. And so we will work as a team to come up with the best care plan for their child. And of course, it's going to be multidisciplinary. So it's not just enough to manage the seizures. We need to address the non-seizure co-occurring conditions, maximizing quality of life, and having this discussion and a plan for a transitioning to the adult world so that it's not emotionally traumatic for families. And so one of the approaches that I always recommend is from the very beginning, we have shared decision making. When I sit down with families, I explain that, my job is to educate you on the treatment options that are available. My job is to educate you on the potential risks. I talk about SUDEP early and often. We talk about the co-occurring conditions. So, I will bring my knowledge to the game. Your job is to be an expert in your child. You know what's going to work best, because at the end of the day, I may make recommendations, but I'm not assuming any of that risk. The families are. The families are the ones taking the child home. And so we need to combine our expertise to come up with a good plan that everybody feels comfortable with. And then if you start with that, then down the road, that transition to the adult clinic isn't going to be as scary, because it's not that, oh, my child is doing well because of this one doctor. No, it has nothing to do with the specific doctor. It has everything to do with that shared decision making that has been going along this entire time. And of course, quality of life needs to be the center of all decisions. We need to talk about seizure treatment, but also a rescue plan. Another little quote that I tend to use with families is, when it comes to epilepsy, we cannot control when a seizure is going to happen, but we can control how we're going to react to it. So the best thing we'll do is we'll have a plan and a backup plan and a backup plan. And that is how we provide some degree of control for these families, recognizing that control, a good seizure action plan means that the child is not being life-flighted to a different hospital. A good seizure action plan means that the child is treated within their local hospital and then can return home, and the family can be there for a sibling's birthday party. When they come into the clinic, we need to, again, acknowledge their expertise. So we may have our own little mental checklist, but at the end of the day, their checklist is more important. So when my families come in, I don't sit down and say, tell me about their seizure frequency. No, it's very open-ended. What would you like to discuss today? One of my favorite moms of a now adult Dravet child will sit down with me and say, I feel like we're in a good place with seizures, but this is what I want to discuss today. And you know what? That is just as important, if not more so. So listen to those parents. When we are first meeting with families, it's important to establish a good relationship of trust. And the best way you can do it is by listening to families. They come in with, with ideas that may not be consistent with what you were taught, but you know what? It's because they're talking to other families who, have things that have worked for them, so they're going to bring their knowledge to the table, and we're going to listen, and we're going to have a good discussion about the risks and benefits. Again, we're going to talk about SUDEP early and often, and listen to families, because they will say certain phrases that tell you that they are ready for that discussion. It's important to do it early. I recommend doing it during that first visit, but if they say to you, could these seizures really hurt my child? They want you to talk about SUDEP, so please take that invitation and talk about SUDEP. Don't ever make assumptions. Don't ever assume that families are aware of resources, but also don't assume that they're not. Just don't assume anything. And most importantly, establish those expectations. Talk about when they should expect to hear back when they send you a message. Talk about the best ways to communicate, and then do what you say you're going to do. We also need to, again, invest in education. So educate families, but before you educate families, you need to educate yourself. So know the best treatment options, know what research is going on, and also acknowledge that families may know more than you, and so when they bring knowledge to you, be grateful. And so there are some issues that come up for caring for underserved populations, many of whom have undiagnosed Dravet syndrome. What do you think some of those concerns are, Shannon?
Yeah, I mean, first and foremost, we all need to see a neurologist or epileptologist that is familiar with Dravet syndrome. And we definitely find in our community that, people that live in more rural areas are going to have a much harder time finding a doctor that understands Dravet. They may have heard of it, but they're not necessarily up to speed on what the most current common treatments are and what they should be trying. And also those families are less likely to have the option to participate in a clinical trial because those providers are less likely to be engaged and even know about the trials if the family was willing to travel. We do have a lot of families that travel to see a Dravet specialist in another state. And so I think for a lot of those families, it's really important that you still have a local neurologist that respects the fact that you may feel like you need to go get an expert opinion, and the hope is that you can have a local neurologist that's willing to work with that Dravet expert and manage your care locally, but then, maybe a couple times a year, you go see the specialist so that when it comes to making major decisions about treatment changes and things, you're getting that kind of input. So, and then, we're always encouraging people, this is your child. Your ultimate control is up to you, right? You want to find a doctor that's willing to, exactly as you said, work with you and come up with a plan together. And just because a doctor says, oh no, you shouldn't do this, if it's something that you firmly believe that you want to try, keep saying that. I may have had to do that a time or two with my own my daughter's doctor. And so it's just really important for families to know their role and to make sure that they're well connected and learning from other parents about what the possibilities are.
And of course, we also have to keep in mind that there are a lot of patients out there that we are not seeing. They aren't getting, their primary care providers aren't recognizing that this is more than just a febrile seizure, and so they're not making referrals. So what do? We educate. There are families who don't trust healthcare professionals, and we have earned that. That's why I said, in preparation for caring for these families, we have to establish trust. We may be dealing with decreased community health literacy. The community, the family doesn't know that having recurrent seizures with fever is something that they ought to be seeking treatment. Or maybe they can't travel to a different state. They don't have the funds, they don't have a car, they don't have the ability for transportation. They are limited by finances. There could be language barriers. And while many of us have language interpreters that are available and able to work with us, there can still be things lost in translation, especially cultural differences. And we can't, of course, forget our undocumented families who are just afraid to come see us. As we talked about before, it certainly requires a multidisciplinary team. So again, we are still preparing to meet this Dravet family. We're going to put together our team that covers all of the co-conditions that Dr. Teal discussed. And remember, this can also include a home health aide, social worker, resource and support coordinators, and advocacy organizations. And fortunately, Dravet syndrome has one of the very best advocacy organizations. And don't forget that primary care provider. I have some patients who don't have a local child neurologist because they live too rural. And you know what? That's fine. I'm going to work with that primary care provider. It's the primary care provider who's going to be managing a lot of the co-occurring conditions. When I need to get echocardiograms or I need to get labs, it is that primary care provider who is ordering those. And now we need to talk about the actual medication too. Of course, we need to have a seizure rescue plan. And remember, you have your plan, your backup plan, your backup plan, right? What families do when the child is in status epilepticus at home, what families do when they're going into a situation where they know a child is likely to have a seizure. Can they give an extra dose of something to prevent that? Families need to know when to call EMS. EMS should have instructions of what they do en route to the local hospital. Local hospital should have a list of what to do. Local hospital, and again, I practice in rural America, so local hospital should know when to call my institution. We give instructions for what to do in transport to my institution. Plan, backup plan, backup, backup plan. And if you're really good, a backup plan. That's how we do. We do know that there are recommended treatments for Dravet syndrome. Most people in this room are pretty familiar with this. First line valproate, followed by fenfluramine, stiripentol, or clobazam, and then moving on. Big thing to keep in mind, though, is every child is unique. There is no one size fits all. Even among the preferred medications. And using these medications can be really challenging. These kids have side effects. And not all of the side effects they have are ones that you necessarily expect, but they'll still do it. Listen to families if they say they're having a side effect. They're right. Medication, especially benzodiazepine withdrawal, is really hard. And again, more medications is not always better. You need to work with these families, have open discussions about our pharmacologic and non-pharmacologic treatments, and again, acknowledge families as the ultimate decision makers. We're never going to put them in a position where they feel uncomfortable. They should never be in a position where they feel like I have told them they have to do something. This is, again, joint decision making. We can also try to use medications to help with co-conditions and certainly try to avoid making them worse. And we're going to use the least number of medications possible. Just recognize that, again, with all of even our preferred medications, there are especially behavioral side effects. And when it comes to behavioral side effects, would you agree our Dravet kids are really, really good at having them? So again, I know we're all taught that valproate's supposed to be good for mood, not necessarily here. So again, we're going to advise families as much as possible, but if they say the child's having a side effect, they are, and so we're gonna listen. But there are some medications that may have some positive effects on those co-conditions. Like with fenfluramine, there's been documented improved cognitive functioning, alertness, academic performance, even improved sleep. We have more seizure-free days, improved quality of life. With our pharmaceutical-grade cannabidiol, there's subjective improvement in cognitive symptoms and conduct, again with sleep. And as you said, sleep is huge, because if the child's not sleeping, nobody's sleeping. When they come in for their visits, we're going to make sure that the child's needs are being met, but also that the family's needs are being met. Yes, we'll talk about seizures, but we'll also talk about behavior problems, again, sleep. Are they eating? We're going to make sure that the family's psychosocial needs are met. If they haven't yet, make sure that you have them involved with a county case manager, because that's how they get access to services. Always talk about what referrals are needed. Are they referrals from their primary care provider to the local community, or are they referrals that need to come from you? And we'll manage our non-seizure symptoms as well. Yes, we can make those referrals, but just as it's difficult to get a Dravet child into an adult neurology clinic, now try to get them into a psychiatry clinic, right? It is really challenging. So we can make those referrals, but we should also be ready to start some of the medications ourselves. And then as they get older, we do need to prepare for transition. I start really early, and we're going to start with the basics of you will transition at some point. We need to start off with that. But then I usually say, at least I'm fortunate that I can keep kids until they are done with the school system, so that's until age 21 or 22. So I will introduce that idea back around age 12. So we're going to start it early. We're going to discuss it often. We're going to recognize that this is a transition. And they will not leave my clinic until they have established care with someone else. The last thing we want is for a Dravet family to slip through the cracks and feel like they don't have support. So I always tell my families that I belong to them until they are physically sitting face to face with their new doctor. If that child has a problem in the car on the way to the new doctor, they still call my clinic, right? Because they should never slip through the cracks. And if it's multidisciplinary transition, then do they move all of their subspecialties over, or do they do it one at a time? And most of the time, that's child and institution dependent. And so our keys, we're going to help identify adult neurologists that are willing to see them. We're going to make sure that families feel supported and have that multidisciplinary care. We're going to help families be educated. And we're going to, again, transition. I always say it's a transition, not a drop kick, right? And so we're going to make sure that they feel supported and they don't ever have that fear that they don't know who to call. We also have to recognize that there's financial and legal matters. Again, that's why we want them to have a care manager. We want them to be plugged in with their family support network. And we will also need to discuss what support they will need for housing, life skills, and vocational training. And so our call to action for our Dravet management plans is...
Right. Well, I mean, I think there's been a recurring theme here that adult neurology providers is a huge concern for our families. And I'm, excited from talking to all three of you this evening to find out that you do have a good transition plan in place through your institutions where you have adult providers that you work closely with and that you know that those families are taken care of. But unfortunately, that's not the norm in our community. A lot of our families don't feel supported as we age out. And I love that you mentioned starting to have that conversation early so that the parent knows, as opposed to a couple appointments before, they're told, oh, by the way, we're going to stop seeing you. And so I think that's really important, making sure that families know about what's available for their kids to do once they age out of school. Because, based on federal law, age 22, literally no more school. They can go to school one day and then all of a sudden, happy birthday, you're turning 22 and you don't get to go to school anymore today. And that can be really hard for our kids because most of them don't have the cognitive ability to understand that. And school is all they've ever known, and for them to no longer have access to that is hard because a lot of us don't have day programs or other things available for our kids. Even if we do have those kinds of programs available, sometimes they don't work for our kids, either because the seizures are too big of a concern or because the behaviors are a concern. And so it can be really frustrating for a family that not only are we getting kicked out of the pediatric providers, but we're also losing access to the school supports that we have in place. And so, people keep asking me, what are you going to do when Elena ages out? I'm like, I don't know, but she's going to be sitting at home driving me crazy. So, and she loves people, and she loves school, and she loves to be engaged. And so, we're going to have to find ways to keep her engaged because she wants to be around other people and be active and do things. So that's a huge concern for our families. And then another big concern is, for most of us as parents are not necessarily willing to think about what happens when we're not able to take care of our kids anymore. And, it can be a huge burden on the siblings. My other two kids, they're not adults yet themselves. And so, we joke a lot that the reason we had a third child was because we didn't want the burden to only be on our second child. Now, we hope that between the two of them, hopefully one of them will have enough compassion to want to take care of their sister. So I think for a lot of our families that can be hard, and sometimes it means going ahead and getting your child put into like a residential living home while you could still care for them, just because you don't want them to have to experience that kind of a change at the same time as losing a parent. And so, for a lot of us as we get older, we know that physically we can't take care of our kids anymore, or we may get to the point where we're taking care of our own parents, and then that makes it harder for us to care for our children. So it's just a lot to think about in terms of how to manage all of that.
Yeah, absolutely. So you've heard it. We have our assignments.
Thanks for that really wonderful discussion, both Katie and Shannon again. Now we get to turn it over to the future is bright for Dravet syndrome, and I'll look at future therapies. One of the biggest things I want to start with, Shannon, is your perspective on what you're seeing thus far. Specifically, if you can comment on disease-modifying therapies, and then we'll go through the data together.
Right. So we're fortunate. I don't know how many of you are familiar with the statistics for rare diseases, but 95% of rare diseases do not have even one FDA-approved therapy. And we have 3 FDA-approved treatments for Dravet syndrome. We are in that 5%. It's amazing, right? But unfortunately, our kids are still having seizures, and it's still pretty rare for our kids to have true seizure control, and even if they do, then they're probably suffering from a quality of life perspective. So we're kind of at an interesting point where we have disease-modifying therapies on the horizon. There are 2 that I know you're going to address that are in clinical trial, and it's definitely an exciting time that gives us a lot of hope, but that's a whole new territory, and every family's different in terms of what they're willing to try, whether they are willing to participate in a clinical trial or they want to wait it out until these things potentially are available.
Yeah, and I think that's what's important for all of us to keep focusing on, is there's still a lot of work we need to do, and we got to do that together. When we talk about some of the investigational therapies, we're going to go through some of the ones that you see here. Bexarcin, which I always wonder, why do we pick really hard names to pronounce? Clemizole, ETX-101, and zosinurin. We're going to do all of those. So let's start with the first one, which is really similar to fenfluramine in the sense that it works on the serotonin 5-HT2C receptors, which are obviously been what we've seen as far as success goes for treating kids with Dravet on fenfluramine. The difference is, this medication is very highly selective for that specific receptor, and you don't need to have the echocardiogram monitoring that is required when you use fenfluramine, so no need for a REMS program. Well, what have we learned thus far? There's been a couple studies I'm going to go through, a 1B and a 2A. They call them the Pacific studies. In this population, there were 52 people between the ages of 12 and 65. It was a DEE basket trial, and so 4 of those were diagnosed with Dravet syndrome. And as you can see, there was a 15-day titration with these 3 different milligram strengths and TID dosing, followed by a 60-day maintenance period. Well, what did they see so far when they do the analysis of these first patients? It's a 72.1% reduction in countable motor seizures in the Dravet subgroup. Now, again, there were 4 kids with Dravet, so not a large N there, but you do see a decrease in seizures. It related to treatment emergent adverse events. So what is related to the medication? They were only mostly mild or moderate. And of course, the ones that you see in many anti-seizure treatments: tiredness, decreased appetite, and constipation. Shannon, before I go on, the side effect profiles, I think, of these medications, both the approved and used, can, as you made a comment earlier, be problematic. Talk a little bit about your experience with the community or even your own daughter with how you want that to be managed. Kate gave us some suggestions, but I'd love to hear that from you.
Yeah, I mean, and this is where our community is very powerful, right? Because a lot of times parents have already heard a lot about a treatment before they even begin. My own neurologist for my daughter, he suggested a medication, and I was like, I'm not super familiar with that one. I go to our support group and I search it, and I saw the negative side effects, and I went back to him and said, nope, sorry, we're not going to do that, because it really is important to look at not just what kind of seizure control are you getting, but, if my kid's behavior is going to be off the chart, then it's a non-starter, right? We're not even can consider that. So, I think that's really an important part of the discussion for parents is even understanding, when they're given the option for something new, what could happen.
And I think that's even probably more important too when you're talking about research studies and clinical trials and how we get those kids access to them. So let's go on. It's important to know for those that are treating neurologists in the audience, there is active recruitment for a phase 3 placebo-controlled study to investigate this product in children and adults with Dravet syndrome. So if you are aware of a child or adult that would be interested in participating in the trial, you could go to clinicaltrials.gov to look for the sites. Many of the folks at this meeting are involved, and I'm sure the company will also be able to help you navigate that space. Let's move on to clemizole, which is also EPX 100. So what's interesting about clemizole is the mechanism of action is related to a histamine receptor, and specifically an antagonist of the H1 receptor. There's high binding affinity to this postsynaptic 5-HT receptor subunit, and you can see the two that are listed. And it's really been identified by screening in a drug library using the zebrafish models back in the day that helped us also find fenfluramine as a possible treatment in Dravet syndrome. So those phase 3 clinical trials are ongoing with children with Dravet syndrome. They're calling it the Argus trial. And again, this is an active recruiting study. If you have people who are potentially interested, again, go to clinicaltrials.gov or search on the internet for sites near your location.
As I've mentioned, the majority of patients with Dravet syndrome do have a pathogenic variant in the SCN1A gene, which is found on chromosome 2. The SCN1A gene encodes for the alpha subunit of the NaV1.1 sodium channel, which is primarily expressed in the GABAergic inhibitory interneurons. And understanding the underlying pathophysiology of this sodium channel and where it's expressed is actually really important as we start to talk about other novel therapies that are in development. So what happens when you have these pathogenic variants in the SCN1A gene? So what happens is if you have a variant in one of the genes, that leads to a loss of function. So essentially no sodium channel is made from that one transcript. And this results in what we call haploinsufficiencies. So essentially in a normal person, a normal patient, we have 2 working copies of the SCN1A gene. But in Dravet syndrome, because one of those copies has a pathogenic variant, that leads to this loss of function, and therefore that one gene cannot make the sodium channel. And so you end up with this haploinsufficiency and leads to 50% less of that sodium channel being expressed. There are many different ways that these variants can lead to this loss of function. You can have missense variants, you can have truncating variants, and you can even have these aberrant splice events or this poison exon that actually leads to this nonsense mediated decay. And essentially that protein is not able to be translated into the functional sodium channel. And so when that happens, and these inhibitory interneurons do not have the full complement of sodium channels, that reduces the excitability of these inhibitory interneurons, right? So you have an interneuron that's main function is meant to be inhibition. And so because of this haploinsufficiency, that neuron is unable to inhibit as it's supposed to. And so when you end up with more excitation because of the reduced inhibition, right? So it's this seesaw, it's this teeter-totter. And basically that leads to this more widespread reduction in the inhibition of the overall network, and that's why it leads to seizures, and we also believe the other non-seizure neurodevelopmental findings. So evidence so far suggests that the impaired GABAergic signaling in these Purkinje cells can also lead to some of the motor function. There's also some basic science hypotheses that suggest that the increased risk of SUDEP in these patients may be due to the increased parasympathetic activity following tonic-clonic seizures. And then again, Dravet syndrome being much more than just seizures. All of the behavioral and cognitive impairments we feel are in some ways modulated and mediated by this reduced GABAergic interneuron expression. And that's why this syndrome is more than just seizures. So therefore, Dravet syndrome, we look at this as not only a developmental and epileptic encephalopathy, but more specifically a channelopathy due to this aberrant expression in that NaV1.1 protein. So what are the therapies that are on the horizon? There's a couple that we're going to focus on in this session that are further along in clinical development. And again, both are approaching it in slightly different ways, but are trying to restore that underlying haploinsufficiency as a result of the pathogenic SCN1A variants. The first one that I'd like to talk about is called ETX-101. This is an AAV9 associated vector-based therapy. And the AAV9 capsid is housing a genetically engineered transgene that is specifically targeting the GABAergic interneurons, right? So not only are we trying to increase that expression of the NaV1.1 channel, but we would love to do it with some cell specificity, right? So in those GABAergic interneurons. And so this transgene encodes for a transcription factor that binds upstream of the SCN1A transcript and promotes increased transcription of the messenger RNA, which then goes through and results, thankfully, in increased functional NaV1.1 production. Another therapy that's in development is called zarivanersen. And this is an antisense oligonucleotide that's targeted at the specific exon that actually has led to this nonsense-mediated decay. And so it's sometimes called a poison exon. Sometimes we don't like using that term because it sounds too scary, but essentially by promoting exclusion of a specific exon, it makes non-productive messenger RNA, which again, if it has this exon included, does not get translated into NaV1.1 protein. By promoting exclusion of that exon, you actually turn that non-productive messenger RNA into productive messenger RNA, and therefore that is able to lead to increased production of the NaV1.1 protein.
So thanks to Dr. Joe Sullivan for that wonderful and educational video. I think it's really important that we understand these treatments that we're going to talk about now and how and why they possibly work for not just seizure symptoms, but those non-seizure symptoms. Specifically, we're talking about what we now refer to as disease-modifying therapies. And I think that's an important opportunity that we haven't quite focused on in the past that we're going to be able to now. So for ETX-101, the first thing I want to talk about is some of the mouse model studies. When you look at that, that's obviously how we're going to have to start this conversation. We have to make sure any treatments are safe and effective in animal studies prior to going into human trials. In this case, they used a mouse model study to begin with. And as you can see, when you control for the wild type mice compared to those that had the SCNA genetic variation and that were given this treatment, you see a dramatic reduction in seizures. And specifically in a mouse model that's similar here for what we use for Dravet, heat-induced seizure frequencies. As we talked about as that being a trigger for Dravet syndrome, it's often really helpful to see what you will get when you have a heat-reduced or heat-triggered seizure as far as reduction goes. And again, promising early results in mouse models. So then that moved the evolution into non-human primates. And in this situation, you would call it a large animal model. And it can be a different model. In this case, the company used a primate. And it was an intraventricular injection that was well tolerated. And there were really no adverse events that were noted, no changes in body weight, temperature during a 28-day watching period, and very minimal elevations in ALT and AST in some cases, but all resolved without any treatment. So where are we right now for that? Because it's really time for the human studies to begin, and underway. These studies are enrolling and they're underway. And at this meeting, there was an important announcement as it relates to some of the efficacy and safety data for the first children given this new treatment. And I'm happy to say that some of these results are really promising. 78% seizure reduction and countable seizures were noted. More importantly, you also started to see significant changes or improvements in some of the developmental screens that were used in this study, specifically the Vinelands. And there were 4 babies who received the Bailey 4, and those babies, that you saw some improvements as far as that goes as well. Obviously early data, but really encouraging that you're seeing such a dramatic response or improvement early in the exposure after receiving this treatment intraventricularly. Now we're going to talk about zorsinurin, zorrevsinurin, or whatever. Again, I'm not very good at these pronunciations. But what's exciting is not the name, but the data that we can share with you. So there are some phase 1 and 2A open label data that I would like to talk to you guys about today. In this study, there were 81 patients between the ages of 2 and 18. What's important is these are kids who take a lot of medicine. And in this study, 85% were taking 3 or more anti-seizure medicines. And they had ascending doses that started at 10 all the way up to 70 milligrams. And this treatment is administered intrathecally in the lumbar space versus intracerebrally. The efficacy was seen at multiple doses of at the 70 milligram dosing. And what you saw there was a 50% or more reduction in convulsive seizures in 80% of these patients at 3 months. And more importantly, that was sustained at 6 months with a 77.8% reduction. Again, it was very well tolerated. You didn't have a lot of adverse side effects. We also saw some disease-modifying improvements related to adaptive behavior, overall clinical status, and quality of life within the first 9 months. Now, remember, we heard from Shannon how important those non-seizure symptoms can sometimes be. To be able to offer treatments that may work outside of just seizure control is really encouraging. And one of the things I do point out in this treatment is you did see a CSF protein elevation. However, we do not feel that's clinically significant. There's more work that's going to be needed as it relates to that protein elevation and what happens. But right now, again, we do not see any clinical relevance to that elevated protein. What about the open label extension? Well, what's really great is these kids now have been getting this medication at maintenance doses at 45 milligrams every 4 months to try to, again, increase that expression of the NaV1.1. And we now have data at 12 months and 36 months with, again, consistent reduction in seizures. I think one of the things that frustrates me about treatments in Dravet syndrome is this honeymoon period where the kids will respond really early and do well, and then that wears off over time, and then you're having to switch treatments. Right now, at 12 and 36 months, it's very encouraging that we're not seeing that with this treatment. The other big thing is, again, that continued improvement in cognition, behavior, and functioning, which is, again, so important to our children. The open label, as far as the extension data, gets the same side effects. Even at 12 and 36 months, we do not think that the elevated CSF protein is causing any significant issues. So where are we now as far as this possible treatment for kids in Dravet syndrome? Well, there's sites popping up every day across the world as far as doing a randomized sham-controlled trial. The age range is 2 years and less than 18 years. It's really important I point that out. The child cannot be 18, has to be under the age of 18. Can be 17, 364 days, time of enrollment or screening, but not 18 years old. The primary outcomes in this study are change in motor seizure frequency, but again, focusing on that disease-modifying treatments, that we're also looking at cognitive functions and behavioral symptoms, and specifically as measured by the Vineland-3. So Shannon, I want to throw it back to you. You know, we went through a lot of different discussions today, but what I love to hear is that, again, people are interested in Dravet in the space and really want to expand our number of treatments and different mechanisms of actions. How does that resonate with you and your community?
Well, needless to say, there's a lot of excitement about these, both of these treatments getting to this point. I think, you know, for most of us, it's like whether we've just started the journey or been on it a long time and trying different medications, like the idea that there could be something that could potentially actually treat the underlying cause rather than just controlling the seizures or the other symptoms is, I mean, almost unthinkable for some of us that could be possible. I think, you know, we all want to cure, right? That's the ultimate goal. We want to cure for Dravet syndrome. That's what DSF is funding research for. We want there to be a day when kids are no longer getting this diagnosis and can have normal, healthy lives. And so, you know, at this point, we don't know what will happen. It's very exciting to see the results that are coming out of both of these trials. It can be difficult sometimes to manage the expectations of the family because they hear the words disease modifying and to them that may mean cure, and that's not necessarily the case. But I think for any of the families that are dealing with Dravet syndrome, if you see any improvement, it's well worth it. You know, obviously less seizures would be incredible, but even if our kids show improvements, you know, cognitive, if their speech gets a little better and they can communicate better, if their mobility improves, if their sleep improves, any of those things are exciting. And it's definitely frustrating for a lot of us that have older kids because these trials are for the younger population. Obviously, there's reasons for that. The earlier we target the underlying cause, the better the outcome could be for the patient. But it's still definitely encouraging for those of us who may have kids that are too old to participate in the trials, but seeing the results that are coming out and seeing some of the older teen patients that are doing well is still encouraging. You know, I don't have any expectation that Elena is just going to miraculously turn into this normal functioning adult that suddenly has a job and no seizures, but I'm still really excited about the opportunity to see these treatments and others potentially become approved and become available to all patients.
Yeah, it's an exciting time, I think, in our space of Dravet. Before I turn it over to the question and answer session, if you are all interested more in learning on Dravet syndrome, Medscape has a lot of educational platforms, specifically this one, Advancing Clinical Excellence, Bright Horizons in Dravet syndrome. If you scan that QR code, it'll take you to that page. I want to first thank everybody on the panel for a wonderful discussion on a lot of different topics in a short period of time. Before I open it up to the questions from the iPad, I really want to ask you all a question as it relates to, you know, some of the newer treatments that we're seeing. Specifically, when you look at these developmental instruments, the Vineland, the Bailey, I'm often asked, is this a meaningful change? You know, we have statistical significance, but is that meaningful change, and how do you measure that with each of these instruments? Shannon, I don't know, you don't have to know specifically about these instruments, and I don't want to put you on the spot for that, but can you talk about that? You alluded to it a little on what meaningful change.
Right, I mean, this is something that comes up a lot within our foundation as well as the community, right? The primary outcome of studies traditionally has been seizure counts. It's measurable, you know, they're having a seizure or they're not. They went from 10 a day to 1 a day, or 10 a month to 1 a month. And that's the easy way to say whether a treatment is successful or not. But for those of us that are living this on our daily lives, it's about so much more than that. And it's definitely encouraging in the conversations that we have with some of these companies to hear that they're really trying to do whatever they can to focus on the other outcomes that may not be as easy to measure, but are really just as meaningful and sometimes more impactful for the families.
Yeah, and Elizabeth or Kate, do you want to comment on what you have been told as it relates to that, or how do you consider that question as far as meaningful change related to these standardized instruments?
So my challenge is that, or I should say my concern is that these standardized instruments do not adequately reflect subtle changes that can dramatically improve quality of life for families. I have a family who the child was treated with one of these medications, and family came to me, they were thrilled because the child had gain the skill of being able to open the door, walk out. They have, the child's area safe, so, cannot run away, but can get onto their own trampoline, which is their favorite thing to do. Now, how do you measure that with a standardized test?
Yeah.
But I can tell you it dramatically improved the quality of life for the family because they weren't going and opening the door 50 times a day for the child to go out to their favorite toy. So that's my concern, is that the standardized tests are not sensitive enough to detect the developmental improvement in these kids, and that subtle developmental improvement really can improve quality of life for the whole family.
Elizabeth, anything you'd
No,
like to add?
I agree. I often get slammed when I'm asked that question by variable people because I think it's so variable. For a lot of my families, 1 day fewer with seizures is meaningful. Like Kate said, going outside, being more aware, smiling, verbalizing more. I think all of those things are significant and agree that might not appear on these testing.
Yeah.
So I think that we all need to appreciate that the measures we have that are validated might not really translate into what's meaningful for the patient and the family.
Yeah, I think that my experience with this has been, it was really during the clinical trials for the plant-based, now FDA-approved cannabidiol product. At that time, I used to have kids come out, or their parents come out of the room like, oh my gosh, my kid is doing so much better at smiling, walking, or, just paying attention. But you're asking me these questions like they're an 8-year-old, but developmentally they're 8 months old. Why don't, if you could see that, they went from 8 months to 15 months. That's meaningful change in our family's life. And so it really got us thinking differently as far as how we address these. And I think the other big thing that for the audience to understand when you're trying to interpret these results, it's important to see that, okay, I think they're individualized, right? A meaningful change by 2 or 3 points in a Vineland, that is significant and statistically so. Ask the family then, what does that translate to? And that's where you're going to get real answers and real hope. So thank you for that. Okay, we have a question from the audience. Can you talk more about how to manage non-seizure symptoms? What do you often recommend in your practice? Kate, I'm going to start with you on that question.
I guess the first question is, or the first response is, you need to ask about them. Families may or may not bring them up. They might not know who to ask. And so it kind of depends on what the symptom is. And then the next question is it something that I can manage, or is it something that requires a referral? Or is it something that I can manage for a little while? I like to keep a couple things in my back pocket for sleep, for behavior. We can't forget that just because they have developmental disability doesn't mean that they can't have anxiety. So we try to keep a couple things in my back pocket to try. Attention difficulties while getting them in to see a specialist. So again, it's a challenging question to answer because there are so many comorbidities. So I would challenge you to first ask the family what they're doing, ask the family what is, how it's affecting them, and what's their most concerning comorbidity at the moment, because I know we also have limited time for these visits. And then see which one can be addressed through local resources, which ones require referral, and which ones can you at least start treatment right away.
Yeah, and I think it goes back to also what you said earlier that really resonated with me is that constant collaboration with the primary care provider and being able to communicate and get their assistance and work together, I think, is an important. Elizabeth, anything you want to add on how you address
No, I think the main thing is to ask. We all know the list of possible co-condition comorbidities, but not any child or person is the same. I think it's important to ask the family, what is like you said, Kate, earlier, what do you want to talk about today? And then figure out. I also often ask, kind of in the Dravet syndrome community, is there experience with this or something? Because I think, again, it's a collective body of experience and knowledge. And I think that for not only Dravet, but a lot of these rare DEEs, oftentimes the family know more about possible co-conditions and management of them than we do.
Yeah.
I mean, we're epilepsy experts. You know,
Right.
we're not really experts in these other things, but
Yeah.
the families in the community often have advice for us.
Yeah, no, I agree. And Shannon, I'm going to ask you a slightly different version of that question in the sense that you have a call to action here with this audience. What does it feel like when your provider doesn't address these symptoms, or what have you heard from your community?
Yeah, I mean, I think for many of us, our neurologist or epileptologist is kind of our first point of contact, right? They're the one that is mostly responsible for managing our child's care. And so that's kind of where we go first, because obviously seizures are a priority. But then we do sometimes see these other comorbidities and things that we need help with. And I know for me personally, like our pediatric neurologist, he's essentially our primary care provider, whether he likes it or not. That's essentially his role. When we've encountered situations where he feels like it's beyond his level of expertise, like labs are showing something, you know, we're seeing some side effects of a medication and labs are kind of hard to figure out, then he started coordinating with our pediatrician so that we could figure out. We ended up seeing a GI doctor. When his kind of standard suggestions for behavioral meds and things like that, once we kind of got to the point where he's like, I don't really know what to do, he suggested we needed to see somebody with more experience in that area. The struggle that most of our families have, though, is those other providers don't know Dravet syndrome. And while they may know how to treat a person that functions at a typical cognitive level or isn't on all of these specific seizure medications, they also, you know, they typically don't understand the whole patient and what the interactions could be. So it can be very difficult to find other doctors who are familiar with it, or at least even willing to take the time to really look into what they need to consider.
Yeah, thanks. All right, our next question is, go over what makes you suspect Dravet instead of febrile seizure types early on. I'll start if I could. I think the biggest one is the hemiclonic seizure with fever that presents in febrile status. You know, I think that's a really high red flag. We've gotten great education to our trainees to recognize that and get whole genome sequencing rapid test so we can get that turned around and diagnosed correctly. So it's helping us diagnose these kids earlier on. You know, it's important to remember that that's not the only presenting seizure type. Obviously, generalized tonic-clonic seizures are a common presenting type of seizure in kids with Dravet. But again, it's usually going to be initially prolonged or in status, requiring obviously treatment. I don't know if you have anything to add to that.
Yeah, I mean, not only is it the prolonged hemiclonic seizure, and remember, rarely these can occur without seizure as well, and it's without fever as well. I have a patient who never had a febrile seizure, but had recurrent prolonged hemiclonic seizures, was sent to me for pre-surgical evaluation. In the hospital, we identified a prolonged hemiclonic seizure coming from the other side. So that's going to be another big clue, is prolonged hemiclonic seizures arising independently from either side within the first year of life. And when I went back to the videos that family sent to me, indeed, the child had never had a febrile seizure, but he was wearing a bath towel with all of them. That a sudden change in temperature from a bath is often a trigger as well. So it's not just a fever, it's a change in ambient temperature, it's a hot bath. So that's going to be another big clue that we're not dealing with febrile seizures.
And I think what's important is if you do get the genetic testing because you suspect a Dravet phenotype, and they came back with a genetic variation in the SCN1A gene, you know, if the other symptoms fit clinically that can go with that diagnosis, you make the diagnosis. But please remember, you can have a genetic variation in SCN1A and not have Dravet syndrome. And so I think it gets to be challenging. I think it's important to partner with people who are expertise in Dravet, specifically interpretation by genetic counseling. And these companies now offer it if you don't have those resources in your local area. Okay, I know we're almost out of time, but I do want this question to be asked. Do you need to treat episodes of twitching of the eyes in Dravet? And I'm just going to twist it without EEG correlation. Non-epileptic eye twitching. Do you treat? Do you not?
Ooh, that's hard. You want to take that one?
I think if it's eye twitching without EEG correlate, not necessarily.
Yeah.
Because we know with Deuce sometimes there's an EEG correlate with the imatinib myoclonus, sometimes not.
Yeah.
And I think that I think you can sometimes tell is there an alteration of consciousness with that eye twitching as an atypical absence, or is it just eye twitching?
That's usually my big trigger. Is what is it associated with? Is it associated with behavioral arrest, especially prolonged behavioral arrest, or are they, still showing me their toy?
And I think in those situations, they're sometimes difficult to discern. And so if in doubt, I just get EEG to capture.
Yeah.
And I agree with both of them. If it's not obviously causing disruption in their daily routines, it's hard to throw medications at it knowing you have potential for side effects. It's all risk-benefit ratio.
So Anu, can I go back to that prior
Please.
question? Because I think all of us were raised, and kind of when you and I trained, and we all know febrile seizures occur in 5% of children.
Yeah.
Febrile seizures can be hemiclonic, complex febrile seizure. They can be prolonged febrile status. But I think now with these emerging treatments and therapies for Dravet and the availability of genetic testing, I think the pendulum has swung to where you don't wait for that second seizure to say, is this epilepsy? You don't even care as much about family history. You say, here's this seizure, let's send the gene panel.
Yeah.
And I think we need to do that, especially with these evolving therapies, knowing that the sooner we effectively treat, the better the kids are going to do.
And we feel that's going to be true even with the existing treatments. If you get them on the correct treatments that have been studied and evaluated in Dravet earlier, we do feel there's better outcomes. And we are now starting to see data to reflect that, and even also experiences in our own practice. Well, thank you everybody for a wonderful evening and wonderful discussion. I want to thank Medscape for giving us this opportunity to share all the insights we have with Dravet, but most importantly, a round of applause for Shannon and for the Dravet Syndrome Foundation for all the excellent and amazing work that they do to help all people with Dravet syndrome. With that, if you'd like to earn CME credit, please scan this QR code via your mobile device and go through those questions and you can get your CME credit. Thank you and have a wonderful evening and enjoy the rest of your American Epilepsy Society meeting, and go Buckeyes.
I knew you were going to say that. Thanks, everyone.
Thank you.